All right, we recording. We recording. We got everything going. Got the screen recording going. All right, gotcha. So this is my episode one of my protocol review series as I prepare for my capstone internship, probably with Wake County EMS in March, which is 2 months away. So I'm going to make an entire series of me reading over the entire North Carolina OEMS protocol book and also the Wake County EMS protocol book in general because they're a bit different. And it's also good for me to know the NC protocol book as well as the Wake County protocol book because I will be doing my capstone internship there in 2 months where my job is to function as a sole paramedic completely by myself. So I need to know everything very well. So the NCEMS protocol book is about 180 pages. Wake County is like 350, right? So what's a good way to do this? So if I break it up into, say, 30 episodes, 30, 30, 40 episodes, and you do about 5 slides from the EMS protocol book to get to 200. And since this is about double, then you do about 10 slides. So that's what we'll do. All right, so first thing I can do is I'll put this maybe over here, so because my face is over here. So what's perhaps the best way to do this? Because if I full screen it, like my face is over here, like on the right. Yeah, but that might be the best view. Oh, well, we'll see it. All right, so this is page one. Oh, yeah, that's definitely not going to work. Okay. All right. Shoot. Okay. So if we go over here. All right, gee. Yeah, we'll just do it like this. Cool. So this is the protocol book. So when you're an EMS provider, right, there are protocols which are written by a medical director for a specific state or a county, which basically outline everything that you need to do in a particular situation. So you'll see at the top here, this is adult cardiac arrest, right? So there are different situations and they all have different categories, and this tells you exactly what to do. So this is for adult asystole, pulse electrical activity, also known as PEA, is basically flatline on the monitor, no electrical activity in the heart during a cardiac arrest. So this tells you what you need to do. So history, sample, signs and symptoms, allergies, medications, past medical history, last oral intake, events leading prior, estimated downtime, so how long were they in cardiac arrest, H's and T's are reversible causes, signs and symptoms, so pulselessness, not breathing, anemic, no electrical activity on the EKG, which means that they are in asystole and they have no electrical rhythm. No heart tones on auscultation, obviously, because they don't have a pulse. So this is basically just the cardiac arrest protocol. So criteria for death, right? So no resuscitation, yes. Decomposition, rigor mortis, like stiff limbs, dependent lividity, so like blood pooling in the back. Blunt force trauma, injury incompatible with life. So say, for example, like a head amputation, right? You wouldn't do CPR on that. So certain situations where someone's, if they have their head amputated and you put them on the monitor and they're in asystole, obviously you're not going to start CPR in that situation. But if there is no criteria for death, you go into the next stage. So you're seeing how this works. There's a protocol book. It's like tells you what to do because we as paramedics, we're not doctors, even though I want to ascend to that level. But criteria for death, no. So you begin compressions, push hard, 2 inches, push fast, 100 to 120 compressions per minute. Change compressors every 2 minutes. Limit changes and pulse checks to not less than 10 seconds. Ventilate 1 breath for every 6 seconds. 32 compression to ventilation ratio for CPR. AED, right? Obviously, this is paramedic level cardiology, but if someone is in asystole, you can't shock that rhythm because there's no electrical activity in the heart. You only defibrillate VTAC and VFib, which is ventricular tachycardia and ventricular fibrillation. So this is kind of like a little side thing here. But yeah, so an AED, an automated external defibrillator, basically checks the rhythm for you. But as a paramedic, you are the AED. You need to know how to learn these rhythms. So this is ventricular tachycardia, also known as monomorphic VTAC, because it's all equal. Polymorphic VTAC would just be all over the place. But you can see it kind of just looks like a mountain. Basically, in this situation, the heart is beating so fast, it's just kind of like it's kind of quivering. VTAC is bad, but VFib is even worse. This is VFib. If someone's in VFib, they're 100% cardiac arrest. It's just like little fibrillations on the monitor. So they're in VFib, the heart is just basically quivering, like it's shaking, like it's not even beating or any circulating blood at all. So they're dead. And then obviously this is what is called is asystole, which is just a flat line on a monitor. And then you also have PEA rhythm, which is like, say, for example, you put someone on the monitor, right? And it has like an organized rhythm. So as you can see here, like this has an organized rhythm. You have the P wave here, you have the QRS complex, you have the T wave. Like it looks like an organized rhythm, but you can feel the carotid and they don't have a pulse. You know they're in PEA, so you can't defibrillate that because there's no actual mechanical blood flow in the heart. At least with these rhythms, like VFib and VTAC, the heart is still like kind of quivering and moving blood, even though it's not circulating at all. It's just like kind of sloshing around. Right? So those are the only rhythms that you can defibrillate. But this situation, you want to do that. Let me put this down here. So yeah, get them on a cardiac monitor. You're going to get IV or IO access. So IV access, you're probably not going to be able to get IV access on someone in cardiac arrest because their veins are going to be flat. So you're going to have to get IO access, intraosseous access. You're going to have to drill into the bone. And obviously you would give epi 1 to 10 for any cardiac arrest to help dilate the blood vessels, to obviously vasodilate, because it makes it easier for you to circulate blood with compressions because the veins are smaller, right? Because you don't have as big of a hose to fill. That's the way I like to think of it. And then I'm normal saline up to 2 liters to maybe give them some fluid that might help if they're dehydrated. And then blood glucose. And then, yeah, pretty much someone's in asystole out of hospital, like they're dying 99% of the time. Unfortunately, but we still have protocols for it. And obviously in any cardiac arrest, there are reversible causes. So for example, hypovolemia, hypoxia, acidosis, hypothermia, hypo and hyperkalemia, tension pneumothorax, cardiac tamponade, toxins, pulmonary embolism, and a heart attack, which is a coronary thrombosis, which is a blood clot in the heart. So yeah, so if you're doing CPR and nothing else is working and you can't understand why someone coded goes into CPR, for anyone that didn't know that, that's what coded means. You can look for reversible causes. So hypovolemia, low fluid volume. Do they need a blood transfusion? Hypoxia, low O2. Is that going to do anything in this situation? Hypothermia, are they cold? That's another thing. They're not. Here's a saying. They're not. Someone isn't dead until they're warm and dead. Obviously, I've never done CPR on someone that's freezing because, I'm 20 years old. I only have 3 years of medical experience. I've only been doing this for 3 years. But one of my instructors at the community college told me a story of one time where he had a little girl that went into cardiac arrest because she was freezing outside in winter, and they worked her. They did CPR on her for 45 minutes and they warmed her up and she lived. She was in VFib and they worked her. So someone's not dead until they're warm and dead. So hypothermia, if someone is hypothermic, especially because it's January 7th, which today was like 70 degrees outside, they're not dead until they're warm and dead. So warm them up. All right. Pearls. What does pearls even mean? Let's find out. Pearls meaning EMS. Healthcare. Pupils eager and reactive to light. So I knew that. I don't know, dude. I guess pearls just means something that's important. I guess. All right. Team focused approach. Defibrillate when indicated, which they're in asystole. You wouldn't shock that because there's no electrical activity in the heart. Do not hyperventilate if no advanced airway, a blind airway insertion device, or an endotracheal tube Compression to ventilation ratio is 30-2. If advanced airway is in place, ventilate 10 breaths per minute with conscious, uninterrupted compressions. Do not interrupt compressions to place endotracheal tube. Consider biad first to limit interruptions. So, say for example, when someone's in cardiac arrest, right? Like they're not breathing. So you have what's called these blind airway insertion devices, which is what is like an eye gel. This is a bad example. Eye gel airway. Eye gel airway. So yeah, this is like an eye gel airway. It doesn't go actually into the trachea. What you're supposed to do is like you basically like just stick it in the person's mouth, and it goes basically over the epiglottis and the trachea. So when you have a BVM mask and you're doing ventilations, it's supposed to ventilate more effectively than obviously just regular BVM ventilations, right? But also, you have what's called ET tubes, which is basically where you intubate someone and you're basically putting the tube directly into the trachea. So the ET tube goes directly into the trachea. So when you put that BVM bag valve mask up to that ET tube, you're basically inflating the lungs directly. The only problem is intubating some people can be extremely difficult, especially during a cardiac arrest. So this is basically saying, what is this saying? Do not interrupt compressions to place an ET tube, and consider the biad first to limit interruption. So if you need to intubate someone during a cardiac arrest, don't stop compressions. They think that's more important in the NCO EMS protocol book. All right, passive oxygenation, optional in agencies practicing team focus approach, pit crew approach. Reassess the biad, the ET tube, in-tidal CO2 device. IV and IO access and drug delivery are secondary to high-quality chest compressions and early defibrillation. IV access is always preferred route. Follow IV or IO protocols, whatever. So CPR, high-quality compressions, and obviously getting that defibrillation in early is ultimately what's going to save their life. Like the IV access and the epi and the amiodarone that you would give them is not going to be as important as that. So if in-tidal CO2 during a cardiac arrest during a code is below 10, you need to improve your chest compressions because the goal is to get above 20. If in-tidal 2 spikes above 40, consider ROS, return of spontaneous circulation, means you got them back. So in that situation, you would want to check a pulse to see if they are back alive. All right, special considerations, maternal arrest. So I guess this is like mother cardiac arrest. Treat mother per appropriate protocol with immediate notification to medical control and rapid transport, preferably to an obstetrical center if available and proximate. Place mother supine and perform manual left uterine displacement, moving uterus to the patient's left side. I think that's because with how the fetus is attached to the vena cava, you have to displace the mother to the left side because of how it just affects blood flow, I think, to the mom's uterus, because I believe that's how it works. IV IO access, preferably above the diagram in pregnant women. Defibrillation is safe at all energy levels. Interesting. So do the 720 joules, just like regular. Renal dialysis, so renal failure patients. So a lot of patients that are on dialysis, will obviously have fluid imbalances and electrolyte imbalances. Opioid overdose is suspected. Administer Narcan, yeah. Drowning, suffocation, hypoxic associated cardiac arrest and prompt attention to airway and ventilation is priority, followed by high quality and continuous chest compressions and early defibrillation. Pacing, transcutaneous pacing. So pacing is basically, so say for example, someone has a heart rate of like 40, right? Which some people, if they're really athletic, might have a resting heart rate of 40, which is Still really low for most people, but most people, their heart rate is normally like 190, say, and you put them on the monitor and they have a heart rate of 40, you might need to pace them, which is basically where you put um, the defibrillation pads on them, and you're basically zapping them with things like millijoules of electricity every single second. You're just delivering small little bits of electricity to them to help them improve their heart rate. Because if their heart rate is too low, and so say if someone has a heart rate of 40, but they usually have a heart rate of 90, there might be a mechanical issue wrong with the heart, meaning that they're not circulating enough blood that they need to perfuse their vital organs. So you're going to need to pace them with a cardiac monitor. Yeah. Pacing is not effective in cardiac arrest, and pacing in cardiac arrest does not increase chance of survival. Success is based on proper planning and execution. Um, Procedures require space and patient access, make room to work, discussion with medical control. Yeah, so it's basically saying, as I mentioned earlier, pacing only works if someone has a pulse. So you're not going to pace someone in cardiac arrest. You're basically just defibrillating them, giving them as much electricity as possible to try to restart that heart. Because when you defibrillate it, when you put them on the monitor and you zap them with like 720 joules of electricity, if you're doing 2 monitors at once, or 360 joules, which is what Wake County does, you're basically depolarizing the entire heart all at once. So your goal is to basically depolarize the entire heart all at once to try to get this rhythm, VFib or VTAC. You're basically getting all of this to depolarize at once. You're basically trying to attempt to restart the electrical activity of the heart to get it back into a normal sinus rhythm, which looks normal. So you're trying to get them back into this rhythm where you have a P, QRS, a T wave, R to R is equal. Now, I mentioned earlier, if someone has this rhythm on the monitor, but you check their carotid or their radial pulse, right? And you don't feel a pulse, then that would be what's called PEA, pulseless electrical activity, which means that there's still electrical activity happening in the heart, but there's no like actual mechanical movement, right? So in that situation, like defibrillating them wouldn't help because there's no actual mechanical movement of blood in the heart. So it wouldn't help. What was I going to say? Also with like radial pulse, like the whole reason when you think someone's in cardiac arrest or they're unconscious, you always check the carotid pulse, because if someone has a radial pulse under 90 systolic, you're not going to feel it. I think carotid is if someone's carotid needs to be at least 60 systolic blood pressure to feel it, but radial is always 90. So if someone's in cardiac arrest, it's just smarter to check the carotid, because if someone has a blood pressure of 70 over 50, which is still terrible, you should still be able to feel the carotid, but you're not going to be able to feel the radial pulse, right? All right. Bradycardia. Bradycardia. Bradycardia, which is slow heart rate with a pulse present. So this is what I mentioned earlier. So you have bradycardia. Brady means slow. Tachy means high. So tachycardia would be a heart rate over 100. Bradycardia would be a heart rate below 60, because normal heart rate is 60 to 100 for a normal sinus rhythm. Yeah, so this just goes over exactly what I just said. So same thing with history. If someone has a slow heart rate, you're gonna want to look into what medications they take. Beta blockers, calcium channel blockers, these and ACE inhibitors are all medications that slow your heart rate. So signs and symptoms: heart rate under 60 beats per minute with hypotension, altered mental status, so they're confused, chest pain, congestive heart failure, seizures, syncope, passing out, chest pain, respiratory distress, hypotension or shock, altered mental status, syncope. Differential. So your differentials are like, say for example, I tell you a patient that has abdominal pain and they're throwing up and they feel sick and they have a fever. Your differentials are things that could be going through your head. So our abdominal pain, is that appendicitis? Is that a kidney stone? Is that just gas? You said they have a fever. Is that are they septic? Right? So do they have a bacterial infection? There are all these things that are going through your mind. So that's everything I just said to you. Those are your differentials. So when I tell you, say, patient has chest pain, your differentials that you should automatically be thinking are, all right, worst case scenario, heart attack, myocardial infarction, Pulmonary embolism, asthma could cause chest pain. Tension, pneumothorax. What are some of the things that could cause chest pain? Myocarditis, pericarditis, tamponade. Yeah. So those are going to be like some of your differentials for chest pain. So differentials are just things that you think about. It's like what could be going on given the scenario. So, all right. So heart rate and symptomatic. So if they're symptomatic with any of these things, there's another protocol for that. Oh wait, never mind. Oh, this is heart rate and symptomatic. So yeah, if they have a heart rate of less than 60 beats per minute and they have hypotension, low blood pressure, they're confused, acute, altered mental status, ischemic chest pain, which is chest pain, congestive heart failure, seizures, syncope, shock. Um, yeah. So typical, they're saying heart rate below 50 beats per minute. So that would be bad. Like me, I have a resting heart rate of like around like 55 because I've always been athletic and like I've always played sports. So last time I checked my pulse, it was like 55. Even though I drink like a lot of like caffeine all the time to stay awake, my heart rate is still like 55, which is insane. So a lot of these protocols will tell you to go look at other protocols, but I'm going to read all of them. So this is saying yes, go to airway protocol, look at the respiratory distress protocol, look at the cardiac and STEMI, which is myocardial infraction protocol. Search for reversible causes. You're going to get a 12 lead, which a 12 lead is the EKG. You're going to put them on the monitor. Anyone that has a chest pain complaint or a respiratory complaint, trouble breathing, or like an abdominal pain complaint, anything that's going on in that area is going to get put on a cardiac monitor just in general because some cardiac dysrhythmias or arrhythmias, same word, used interchangeably. It just means like some rhythms that could be off or look different could cause like shortness of breath. Like SVT can cause shortness of breath, right? SVT is a rhythm that I'll basically teach all this later. But yeah, so search for reversible causes, get them on a 12 lead, get them on a cardiac monitor, get IVIO access. Most of the time with most patients in the back of an ambulance, you're going to want to get IV access. Say, for example, if they deteriorate and you need to push a medication quickly, you're going to get IV access. And most of the time when you bring someone to the hospital is going to get blood work on them. So every patient that I usually have, I'll just say like, hey, like I can get an IV on you right now. I can stick you right now, or we could wait for you to get to the hospital. It's up to you. They're going to do it anyway. And some of them will say, yeah, sure. And some of them will say no. But yeah, cardiac monitor, paramedic. So this means paramedic. Advanced DMT could give someone a normal saline bolus. I guess the reason you would give someone a fluid bolus if their heart rate's low, I guess it just depends if like they appear really dehydrated. Like obviously like someone like me, like if you put me on the cardiac monitor, I had a resting heart rate of 55 and I wasn't symptomatic with anything, you wouldn't give me like any IV fluids because obviously like I don't need the fluid volume replacement. Like I'm not symptomatic from anything. But like as it says here, if someone has a low heart rate and they're also hypotensive, then you want to give them that fluid volume replacement because they're probably not circulating enough fluid. They might be really dehydrated, especially if like they've passed out or they're confused, they're hypotensive. You're always going to want to give someone fluid, especially if they have a fever and you're suspecting that they're like they've been throwing up, really nauseous, been having a lot of diarrhea. Like fluid is definitely going to be indicated because that might be why they're confused. Atropine, you can give 1 milligram IVIO. Atropine is a medication that can help speed up your heart rate. Also epinephrine, 1 to 10 micrograms IVIO. Titrate that until the systolic blood pressure is above 90. And then also dopamine, you can drip a medication for 20 micrograms per kilogram per minute IO of IV. I need to make another video explaining like drug calculations and how you explain like drip math. And then agency vasopressor. So a vasopressor is just a medication that will vasodilate, increase your heart rate and your blood pressure. So epinephrine is a vasodilator. And then if no improvement, go to pacing, which is what I said. And then consider sedation. I don't even know why that's in here. That what is that? Is it midazolam? I'm pretty. That's Versed. Midazolam. Yeah, midazolam. Yeah, yeah. Midazolam is like the actual name for like Versed, which I guess Versed is like the brand name or whatever is the name on the ambulances that they have for it. Okay, okay. And then obviously you check reversible causes. Reversible causes for everything. You want to be thinking about everything. Bradycardia with the pulse present. Um, checking your mental status, skin, heart, lung sounds, palpating the back and the abdomen, identifying signs and symptoms of poor perfusion caused by bradycardia. That can be an issue, especially if their heart's not beating like it normally is, not beating fast enough. They're not circulating the blood and the fluid volume that they need, which would why IV fluids would be indicated. Consider hyperkalemia with a wide complex. So a wide QRS complex. Consider hyperkalemia. Give calcium chloride or gluconate in addition to sodium bicarbonate if hyperkalemia is suspected. Because hyperkalemia means high potassium. So if you give someone calcium or sodium bicarbonate, which I guess sodium bicarbonate, I know that's really alkaline. So it'll help like neutralize it, I guess. I just know like certain electrolytes can cause electrolyte abnormalities. And there are medications that you can give to reverse those electrolyte abnormalities. Hence why we have the protocol book. So, but yeah, with the paramedic knowledge is more just like understanding basically what's going on in every system of the body, not to a very low grade, but enough to like function basically as a doctor outside of a hospital. But obviously, like doctors go way into like more depth on everything, like how things work at the cellular level, versus like paramedics don't. It's like a lot of these, like this protocol book is just basically just a doctor that wrote this for the state and said paramedics are going to follow this and do this in different conditions. And then a bunch of other doctors probably met together and signed off on it. All right, so hypoxemia, which is low oxygen in the blood cells, is a common cause of bradycardia. Ensure oxygenation and support respiratory effort. So give oxygen and any other respiratory treatments that may be necessary. Atropine is considered a first line agent in bradycardia. Ineffective and potentially harmful in cardiac transplantation may cause bradycardia. That's interesting. So atropine is a first line agent against bradycardia, but it could be harmful if someone's getting a heart transplant. I guess it's interesting. I didn't know that. It's a lot of facts. Medicine goes really deep into everything. Symptomatic bradycardia causing shock or Perla arrest condition. Yeah, so if no IV access, start pacing, like what I said earlier, then administer atropine and or epinephrine. Epinephrine or dopamine may be considered if no response to atropine. Arrhythmia, all right, so symptomatic condition. What is a symptomatic condition? A symptomatic condition is when an arrhythmia is causing symptoms such as palpitations, lightheadedness, or dyspnea. So dyspnea is like that's what I'm looking for. Isn't it like passing out? I think I need to refresh my vocabulary. Dyspnea, shortness of breath. Yeah, dyspnea, shortness of breath. Cool. Yeah. So if they have any of these things, they're considered symptomatic. and symptomatic bradycardia occurs at rates below 50 beats per minute, and search for an underlying cause. Serious signs of and symptoms of bradycardia: hypotension, acutely altered mental status, signs of shock slash poor perfusion, aka hypotension, low blood pressure. They're going to look very dehydrated, confused, dry. Yeah, they need fluids and maybe a vasopressor after 2 bags of fluids. Chest pain with evidence of ischemia. So, like if you put them on the cardiac monitor and you see ST elevation, you can probably assume that they're having a heart attack. That's not good. Or T wave inversions, which is a sign of ischemia, or ST depression, which is a sign of what's called an NSTEMI, which doesn't mean someone's having a full blown heart attack, but they're having like an occluded vessel to some extent, which means that that area of the heart is hypoxic. It's not getting enough oxygen. It's actively dying, right? Because it's kind of suffocating, but it's not a full blown heart attack where that area of the heart is not getting any oxygen at all. So they need to go to a cath lab. Transcutaneous pacing procedure. We just talked about this. Indicated with unstable bradycardia, unresponsive to medical therapy. If time allows, transport to specialty center because pacing is a temporized measure. Permanent pacemaker will probably be needed. So a lot of these patients that you'll need to be paced will get like pacemakers, which is basically like an internal like pacer. So that's what someone says. Oh, like I need a pacemaker. And they need to be paced, right? And they'll get a pacemaker probably because they might have an AV block or first or second degree block, which I'll have to talk about when I do my cardiology course. All right, consider treatable causes for bradycardia. Say, for example, like beta blockers. I'm pretty sure for beta blockers, you can give glucagon. It's weird. Glucagon is a medication that improves your blood sugar, but also if someone like has like a beta blocker overdose, this was a test question. That's how I learned it, bro. That's how it got stuck in my head. So beta blocker is a medication that lowers your heart rate. So if someone has a beta blocker overdose, say like an older person, they take too much of their beta blocker medication because they have hypertension, they have high blood pressure. That could obviously drop their heart rate, right? And you could give glucagon, which is primarily a medication to increase blood sugar, to actually increase their heart rate. And that is because it's like the same mechanism in glucagon that glucagon basically like works on some cellular level to increase your heart rate. Because how it works is basically whatever the beta blocker suppresses, glucagon like acts upon. I just know that that's how it works. You like, bro, I've learned this the hard way. We can ask Google. We can say, why, so you can tell I'm not lying. Why does glucagon help with beta blocker? Yeah. Bro, I know it's a thing. Beta blockers inhibit myocardial receptors. These receptors act normally through a second messenger system, G proteins, to activate. It's like CAMP. So beta blockers inhibit CAMP. And I know that glucagon like increases CAMP or whatever. So glucagon can indirectly fix a beta blocker overdose because it works on whatever chemical. It basically prevents the inhibition of the chemical that the beta blocker inhibits. It's the best way I know to describe it. I learned that in class the hard way. I know it's super random. Who knows if I'll ever even need to know it, but that's interesting. All right, now going to adult cardiac arrest. All right, so criteria for death, we already talked about. Like, obviously, if they're obviously dead, you're not going to start CPR. But if there is no criteria for death, you can go into this. So begin CPR, push hard, push fast, change compressors every 2 minutes. If ALS is available, so this is the EMT version, but we're the paramedics, so we are ALS. We are advanced life support providers. So ALS available? No. Shockable rhythm? Yes. You would use the AED, continue CPR, but we're paramedics, so we're going to look at the ALS version. So cardiac monitor, you're looking for shockable rhythm, VFib, VTAC, or torsades de Pointes. Should probably mention that. Torsades de Pointes. So torsades de Pointes is basically polymorphic VTAC. So mono means one, poly means multiple. So this is like, yeah, it's polymorphic VTAC, but the word is torsades de Pointes. You can see it kind of looks like VTAC. It's the little morphins here, and then it like the mountains here, and then it like gets like little fibs here, like kind of goes in between. That is a rhythm called torsades de Pointes. Yeah, it goes in and out. But you would treat it the same way, basically VFib or VTAC. You're going to defibrillate it and you're going to shock them because they're dead and their heart is quivering. So that's what you're going to do. So cardiac arrest, shockable rhythm, no, asystole protocol. We just went over that. Yes, VFib, VTAC protocol, which is another protocol, airway protocol. Arrest secondary to opioid overdose. If it is, you're going to give Narcan, right? And there are adult and pediatric doses for that. Cardiac arrest adults, pearls, team focus, do not hyperventilate, passage of oxygenation, check end tidal, reassess ET tubes, blunt airway insertion device, get IVIO access, defibrillation. Follow manufacturer's recommendations concerning defibrillation / cardioversion energy when specified. Charge defibrillator during chest compressions. So, for example, if you know you need to do a pulse check to see if you need to defibrillate someone, you'd obviously want to charge a defibrillator before you stop compressions, right? Like that makes sense. So you keep as much time on the chest as possible to increase perfusion as much as you can. So you're going to charge the defibrillator during compressions. Yep. End tidal CO2. Try to get it above 20, as we just said, 20, 40. Same thing, maternal arrest with the mom, renal dialysis, opioid overdose, strand asphyxiation. Yeah. So, yeah, I think this is exactly just copy and paste from the asystole slide because it's the exact same thing. But I got through 6 slides of the NC one. And now to do this Wake County one. All right. All right, so this is the Wake County Protocol book. All back real quick. I gotta go take a leak. All right. So this is the Wake County Protocol book. So basically, how it works is you have a protocol book for the state, right, which was made for the state, and then obviously each individual county or EMS system has their own protocol book, which is made by the medical director of the county and signed off by that. So you might be asking me, Chase, why are you studying the NCEMS? Why are you studying the Wake County Protocol book when you just need to learn the state one, right? Well, the thing is because I'm doing my internship at Wake County. So I need to know their protocols, and obviously their protocols are might be slightly different than the state one. So I think it's good to review it. All right, so this is kind of like title page, right? Yeah, as you can see, there's a lot to go over. This is all the stuff you have to learn for a paramedic. So this is airway devices. This is assessments, cardiac procedures, IV access, respiratory procedures, universal health care, wound care, trauma procedures, universal airway, adult cardiac, adult medical, pediatric, obstetrics and newborns, toxins, special considerations, diabetics, bites, drownings, hyper and hypothermia, traumas, burn injuries. Yeah. Introduction. This document describes the measures by which Wake County EMS will continue to provide the highest quality of pre hospital patient care, which I will do on my internship. So, yeah, just scroll through all of this. Cool. So, this is the first page. This is kind of a depressing start. This is deceased subjects, organ replacement. Yeah, so all this will be good to know. I guess I'll read the first one and I'll stop because it's 11:10 p.m. and I'm kind of tired. All right. Criteria for death or withholding resuscitations. You know how I said earlier there are certain situations where you wouldn't start CPR on someone. You wouldn't try to do what's called resuscitation, which is why some older people have what's called DNR orders, do not resuscitation orders, because they just don't want to be resuscitated. They're like, if I die in my sleep, I don't want you to try to do CPR on me. I don't want you to try to intubate me or drill me. Which, who would want to blame them, right? Policy. CPR, BLS, and ALS treatment are to be withheld only if the patient is obviously dead. See procedure section or has a valid North Carolina do not resuscitate order from and or a medical order for a scope of treatment. EMS personnel shall honor a valid physician orders for life-sustaining treatment. Yeah. Purpose. The purpose of this policy is to honor those who have obviously expired prior to EMS arrival, to honor the terminal wishes of the patient, to prevent the initiation of unwanted resuscitation. Procedure. What does this go on? All right. If a patient is in complete cardiopulmonary arrest, clinically dead, and meets one or more of the criteria below, CPR and ALS therapy will not be initiated. So, body decomposition, you can imagine that. Rigor mortis, so like say like their arms are really stiff, they've obviously been dead for a couple of hours. Blood pooling, dependent lividity, injury not compatible with life, decapitation, burned beyond recognition, massive open or penetrating trauma to the head or chest with obvious organ damage, meets criteria established in traumatic arrest protocol. If a bystander or first responder has initiated CPR or AED prior to ALS personnel or paramedic personnel, arrival in any of the above criteria are present, the ALS provider may discontinue CPR efforts. All other EMS personnel levels must communicate with medical control to discontinue resuscitative efforts unless specifically addressed in the trauma arrest protocol. If doubt exists, start resuscitation immediately. Once resuscitation is initiated, continue resuscitation efforts until resuscitation efforts meet the criteria for discontinuing them, and patient care responsibilities are transferred to the destination hospital staff. Yeah, that's pretty depressing to be on the first page of protocol review series. Nothing really interesting, just not doing CPR. But yeah, there are these things called DNR orders, which are legal documents that a lot of patients will have at like nursing homes or whatnot. So if that is present, you can't do CPR on someone. And if someone says they have a DNR order, but they don't have it, you still have to work them. You still have to work the code. That is the legal requirement of that. So yeah, this is my first episode of the protocol review series. Yeah.